Brad, I believe this is your second lecture of the year already, isn't it? Did you do the, no, we
I
had,
didn't.
we had
Scott,
Scott.
yeah, Scott took my place. So this is you only have to listen to me once. So
Well,
you're
we
welcome.
appreciate it, Scott, and we're looking forward to your talk today. And this one is, I say this every week, but this is a fascinating topic as well. So Brad does a great job of talking about hospice regulatory and making it interesting. So this is probably the best way to describe this. So with that, Brad, built you up there. We'll let you have at it. So
Great. Thanks, Joel. I don't know about interesting or helpful, but it's a topic I like talking about because it is what I do every day. And hopefully it'll make some sense at the end. At least my goal in this is to help adult providers, if they're faced with the situation of saying yes to a pediatric patient, be able to say yes and know where to turn for help to getting to yes. So this is about concurrent care in pediatric hospice, about how to navigate it, and I think important lessons for adult folks. Now, I wish it was as clear as that nice compass of north and south there. Let's see if I can get this to advance. And I tried to update this and make it not the same presentation I gave last year. So I changed the confusing picture from a roller coaster to what seems like a super clear intersection. I used this in a past talk, and someone told me afterwards that it's a real place, which is very shocking to me. But I feel like in the pediatric hospice world, this is what it feels like to many providers, especially in the adult world. And much like on this road, people are probably like, I'm just taking whatever road. I don't know where I'm going. I think many times adult providers just say no because they don't want to deal with what is very confusing issues in the peds world at times. So hopefully at the end of this talk, all of you will feel a little more confident that, oh, okay, I get it. I understand what this is all about. And I know who I can talk to help me say yes to taking care of children in the hospice setting. So my goal is to talk about some pediatric hospice data and pediatric death data, discuss concurrent care component of the Affordable Care Act, which many of you are aware of already, discuss why I both love and at times hate concurrent care, and identify resources for all of you to deal with the nuances of taking care of children in hospice. So I start with a patient case. Now, this is a made-up patient. It's sort of a conglomeration of kind of the majority of our patients kind of fit this general picture. This is a 6-year-old with severe neurologic impairment due to a very rare genetic syndrome, the type of syndrome that's like, 1 in a million or 10 cases in the world kind of thing. He has chronic respiratory failure. He is dependent on a trach and event. He has a seizure disorder, is on multiple different seizure meds, but still seizes daily at least, and is dependent on a G-tube. He has a declining clinical course over the past 6 months with multiple hospitalizations for pneumonias, seizures, feeding intolerance, now has new heart failure. That hasn't responded well to medical therapy. And the question is he sort of stuck in the hospital and someone brings up hospice as a way out? So the question is he hospice eligible? Now, all of you deal with similar diagnoses and things, maybe not in the pediatric world, and might see some stuff in there that make you think, yeah, there's some parts in there that might be hospice eligible. But the question is this the patient that we would take on from a pediatric perspective? So we'll come back to him in a little bit. So I often start with just talking about death in pediatrics in general. When I tell people that I work in pediatric hospice, they don't even realize it's a thing in the general public oftentimes. But the fact is, death does happen in children. About 30,000 kids a year die in the U.S. In Michigan, that number's around 1,200 a year. Depending on the year and how things are counted. The majority of those deaths are in infants, so in children less than 1 year of age. So this data is a few years old now, but I think the categories still apply. If you look at all infants, cause of death, congenital malformations, genetic syndromes, things they're born with multiple different organs affected is by far the leading cause of death, followed by short gestation or low birth weight, i.e. severe prematurity. So those of you that rotate with us, you've sort of seen a lot of these patients in our NICU, and we have very interesting conversations around survival prognosis when you are 22 weeks gestation or 23 weeks gestation, which is a number that is moving down and down. When I was a resident, it was 25, 26 weeks, and that number, the age of viability, has become lower and lower. And that is still the leading cause of death in that age group is those congenital malformations and severe prematurity. Now, on this table, you'll see something called CCC. Those are chronic complex conditions. So if you're outside the immediate newborn period with those things that you may not survive in the first week or two. The leading cause of death in those youngest children is severe congenital heart disease, followed by other congenital genetic things again, and then respiratory, because many of these kids, if you're born at 22, 23 weeks, 24, 25 weeks, you are going to be dependent on a ventilator for quite some time, understandably. Now, if you move in the older age group, kids over 1 to 19, I find it interesting they used 1 to 19 because in pediatrics, usually everything is 18. But for this data, they go up to 19. Some studies look at up to 20, so the data gets really confusing. But by far, as I'm sure all of you are aware, the leading cause of death in children overall in that age group are actually non-medical things. It's accidents, it's suicide, and assault. So all pretty awful and tragic. This is all awful and tragic, but in a different way for those top three. And yes, that includes firearm deaths, which is a whole different conversation, but that is lumped in that accident category, which is, depending on, again, what studies you look at, the leading cause of death in that age group outside the newborn period. But if you look at medical conditions to the right there, the chronic complex conditions, cancer is the largest leading cause of death in children over age 1, followed by neuromuscular, which they lump both neurologic and neurodegenerative conditions together. So things like muscular dystrophy, adrenal leukodystrophy, the degenerative conditions that are not curable. And then the third one is cardiovascular. So again, severe congenital heart disease, which we can palliate with different surgeries, but eventually will progress and need heart transplants and things like that. So I include this slide just to kind of point out, well, one, what do kids die of? And two, to remind people that, yes, kids do die. This is the reason that I have a job. It's easy to look the other way, but children do die and they deserve dignified care at the end of life, which is why I do what I do and why I'm talking about pediatric hospice in general. So looking at where kids die, this is the other part that surprises people when I, again, delay the general public about like pediatric hospice is a thing. We didn't realize that this even existed. Children do die at home. It's not nearly as common as in the adult world. This data is old, I'll show you an updated slide, sort of. This one parses out by year. So again, as I mentioned, the vast majority of deaths are in kids less than 1 year. And those are also the kids who are less likely to go home, which kind of makes sense because those are often kids who are in the neonatal ICU and they never even have the chance to leave the hospital, which I'll come back to in a minute. As one gets older into the 1 to 9 years or 10 to 19 year categories, you do have a higher chance of going home if that is indeed what a patient and family's goals are. But still, as you can see, 21, 22% is not nearly as often as it happens in the adult world. And I'm not sure this will ever really change entirely. In updating this lecture, I did find this study from last year that looked at location of death. Unfortunately, it did not parse it out by ages as the other slide did. It just looked at these different locations, which you notice that's a pretty remarkably straight line from 2003 onward. I don't know what happened in 2009, and I also don't know what other location is. If it's not hospital, home, hospice facility, or long-term care facility, I don't know what exactly happened in 2009 that kids were dying somewhere else, at least a small increased proportion of them. You'll also notice a little bit of an uptick from 19 to 20, which I assume has something to do with COVID. It's interesting because in my experience, that I think certainly in the adult world that may have changed location of care, but in the peds world, I don't recall a lot of, chronically ill kids suddenly dying at home rather than the hospital during that time period. What I'm interested in is what does it look like since then, which obviously that data will lag a little bit. Our own institution just started, Helen DeVos Children's Hospital just started a pediatric critical care transport designed obviously to bring kids to the hospital from regional hospitals, outlying areas with our own staff. We've actually used that for the reverse as well. And that was part of their business plan, was to be able to take kids home from the hospital whose families wanted them to die at home, but they were clinically too unstable to get there. Obviously in a private car, they might still be intubated. How do we do a de-escalation of care in the safest way possible at home? And we've done that twice already since they've existed in March in some pretty cool ways. So it may not change this graph significantly, but for our patients we take care of in our area, there is actually a much cleaner way, a safer way to get those kids home when before they may have been stuck in the hospital. I've done it for years, once or twice a year, but the transport part was always tricky because it was not our own providers, it was not our own institution. This new critical care transport has been a bit of a game changer that we know we have that piece covered in a much more meaningful way that we can work hand in hand when the goal is to be home. And I could perseverate on that for a while, that we've done some pretty cool things already with that team. When a family just wants to be home, just wants to be on their back deck looking at the sun. That was one this summer. And when a family tells me that, I'm like, we can make it happen. We'll figure it out. And there have been a couple cases where the child's been too unstable and there is too much risk that something will happen. They're further away. But for the most part, I get pushy and say, we have the critical care transport. Let's do everything we can to honor that wish to be at home with their family, with their dog. That is a far better ending than in the hospital. So it doesn't happen as much as in the adult world, but it certainly is something we try to do if that's within the goals of a patient and family. Now, one challenge off the bat for pediatric hospice, and I shared this slide last year, is whether it's available or not. So this is from NHPCO looking across the U.S. about availability of hospice, palliative care, or both. First thing you'll notice is there's a whole lot of blank areas where neither service exists. I think this data is quite messy, and I know that because of the state of Michigan itself. Maybe I said this last year. If you're in Lake Huron, apparently you have very good coverage, because I'm not sure what happened to the state of Michigan there, but it got a little out of order. And you'll see the blue parts that have both in Michigan. I'm assuming that is the Detroit Ann Arbor area and the sort of Grand Rapids Kalamazoo area, because I know their services there. But the takeaway from this slide is it's not available across the country. I also don't know what happened in Arkansas, where apparently they have great services throughout the entire state, which is a little bit shocking, because I think there's some pretty remote and rural areas of Arkansas that I'm guessing do not have necessarily all the services available. We're very fortunate in Michigan, and I'll talk more about the teams I work with, where I'm confident about pediatric coverage in most of the Lower Peninsula. But what this slide really speaks to is the challenge that pediatric programs have, that some areas you see in dark blue, great, it's covered. There's lots of areas that are not. And just to the south of us, Indiana is a good example of that. I have colleagues in Indiana, or families that have moved from Indiana, have talked about their struggles of finding providers. In Indianapolis, for example, there are multiple different hospices there who might take a peds patient every now and then, but it's not consistent, and it's not a good collaboration with their palliative care programs at their very large children's hospital in Indianapolis. So as I'll speak to a little bit later on, I think we're fortunate in Michigan for what we can provide. But that's one of the biggest challenges in peds, is it's not readily provided. And if it is, it gets very confusing, and concurrent care, as I'll talk about, is often not even offered because of its confusion, as we'll see in a minute. So I mentioned the team I work with is out of, well, I'd say Hospice of Michigan. That's kind of who covers the Grand Rapids and West Michigan area, but also now works with Centrica down in Kalamazoo and Arbor Hospice on the east side of the state. It's all part of the same organization, and their pediatric programs are the Joellen Nyman Anchors Programs for Children. That's a person who has been very philanthropic in supporting our pediatric efforts. But the Anchors program is where a lot of this pediatric data comes from. Now, overall, as you all are aware, the vast majority of hospice patients are not children. The data that I could find from NHPCO kind of lumps it as older than 65 and less than 65. So not surprisingly, most hospice patients are over 65, only 15% younger than 65. And obviously, you're probably talking 1% or, I think when I looked at, I found a number somewhere of 4% or something of less than, 21. And it's probably even smaller than that. Our statewide programs serve about 90 patients per year. And about 45 deaths last year or so. There was some mergers, so the data gets a little skewed, but it's around that. So not a massive number, but not insignificant number of kids that need these services either. The length of service is different, I think, in pediatrics versus adult. There are some very short length of stays, as there are in the adult world, and about a quarter of the patients that we serve are on service for less than 7 days. These tend to be, in my experience, either a child trying to leave the NICU. They're stuck in the NICU and the family just wants to go home. And we are going to do a de-escalation off a ventilator either from the NICU or the PICU. Obviously, that'll be a shorter length of stay. Or a child with a congenital anomaly born in the hospital. The family does not want to go down the aggressive route, so we get them home quickly and they die within a couple of days. That's not uncommon at all. But the opposite is also true. I've taken kids home who we are supposed to go home and they're supposed to die relatively quickly, and suddenly it's 6 months later and they haven't, or it's quite a bit later and they haven't. So about 10% of patients, the length of stay is actually over 180 days. And I have a patient right now that's been on for 5 years. That's my longest one right now. So that length of stay can be on both ends of the spectrum. So what patients do we actually care for? Newborn through 20s question mark. And I say 20s question mark because our pediatric programs get referrals for plenty of patients who are in their 20s that have more pediatric diagnoses. Now, sometimes it's a 25-year-old cared for by our pediatric oncology team because they have a pediatric tumor or they've had that tumor since they were 15, and now it's finally at a point where it's not curable. But also we get referrals for kids in their 20s who have basically all the things that I described in that 6-year-old. They have severe neurologic impairment. They have a rare genetic syndrome. They're still cared for by pediatric programs, so we'll take them on our service. Excuse me 1 minute. As far as the diagnoses, if you look at the census across the board, it's about 40% oncology. Now, this is something I've had to fight against for years as I established the palliative care program. And then even talking about pediatric hospice, many people just assume it's oncology patients. Now, I'm an oncologist at heart, or a former one. And the program sort of grew up in the hemonc world at the children's hospitals. So it took a while to convince people that it's not just about oncology patients. And our hospice data would suggest that. I actually think 40% for the patients I serve on the western side of the state, I actually think this is a little bit different. I'd say it's more like a third oncology patients, maybe. It goes in waves, obviously, but a lot of the patients, the majority of patients, are not cancer patients. These are kids with congenital heart disease, as I mentioned, with progressive neurologic diseases that are not curable, with rare genetic syndromes. And then that leads both of those, or all three of those categories, really lead to chronic complex conditions that I mentioned before. So that's the majority of kids that we see, really both for our palliative care world and then the hospice part when it's appropriate. But the question is, when is the hospice part appropriate and what does life look like for those kids? So the vast majority of kids we see have things that I would argue we are not great about prognosticating. We simply don't know. We've all seen, we're all well aware of the way that people die as far as the graphs, as far as, an acute trauma where things are fine and then unfortunately the end comes, or a cancer journey or other chronic conditions. For pediatric patients, and I borrowed this from one of my mentors, Joanne Wolf, out at Boston Children's, this is what life looks like for many of the kids that we follow from a palliative care perspective, where it's functional status declines on the left, and then time on the x-axis, x-axis there, that these kids do decline over time. And there's crises. Each one of these blips down, maybe a hospital stay. One of those may need, I use quotes around need, a tracheostomy. And these kids do decline over time because of their condition that is not curable. Now, the problem is, what is the time? You notice I didn't put any actual time on there because this could be 6 months in the NICU. This could be 3 months in the PICU. This could be 18 years. And the challenge is for many of the kids that we follow, we just simply can't prognosticate. So you take a rare genetic disorder and you look up in the literature about what is the life expectancy. And it'll say things like, well, most children die before school age or die by age 4 or 5. But long-term survivors have been reported, which means either they're going to die early or they'll die later, which is kind of true for all of us if we think about it. So that's at the heart of what we do on the palliative side, is try to work with families. And we meet families time and time again who say, yeah, their doctors gave them this diagnosis with this rare genetic thing at age 2, and they said they wouldn't live another year, and here we are 10 years later. They still have the same thing. They still have this decline, but they've outlived what we thought. Does that mean they're going to live forever? No. Does that mean they're going to live to age 18? Probably not. So this is at the heart of what we do on the palliative side, is try to work with families around what does this decline look like, and when are you perhaps ready to make different decisions or view your child's care differently based on what their body's telling us, right? We can read literature all day long and be smart geneticists and all kinds of folks, but we simply don't know. The child teaches us based on what their needs are. When do they become dependent on a machine to breathe? And is that something the family wants to pursue for that child? And that's different for every family, and it's okay. But that's why we have those conversations. But it does make the actual hospice criteria a little bit challenging, or I would argue a lot challenging, because as opposed to the nice big books about adult hospice criteria and different things that make one eligible, you won't find that anywhere for pediatrics. So I, for years, have used these three things as my criteria, and I was pleasantly surprised, or maybe just relieved, when I learned that other colleagues, like at Mott, who I know really well, who have my same job, Mott at University of Michigan, their pediatric programs use the same sort of three criteria, that you have some sort of a terminal diagnosis. Now, this can be really hairy because some people say, well, terrible hypoxic ischemic encephalopathy, that's not really terminal. Well, I'd argue that over time, that child who has chronic lung infections, chronic respiratory failure, and things about trachs and vents come up, that kind of is terminal. If you can't breathe on your own, you need a machine to breathe for you. You kind of just defined what might be a terminal diagnosis. These are not children that have simply asthma and a family's kind of tired of dealing with their asthma. Let's talk to hospice. That's not what we're talking about. These are kids that have those variety of conditions that will progress over time. As I mentioned, we don't exactly know that time frame, but it will get worse over time. And we may band-aid a lot of things, but we don't have that cure that's going to fix everything because of the nature of their disease process or their anomalies. And they tend to have clinical decline, obviously, over time. Now, I'm always quick to point out that clinical decline might be very obvious to us by looking at their hospital admissions over the past year and notice, like, wow, they're in the hospital every month or every other month for a week or two or three at a time. And that might be pretty obvious. And these are families that start mentioning to the nurse at the bedside, if I'm not sure I can keep doing this, I don't know if I want to put them through this month after month. Those are all big red flags and signs to ask more questions, right? About, well, tell me more about that. Tell me more about your concern. What have you thought about maybe differently? But this decline may also be at home. I've had lots of families over the years mention to me when I ask how have things been going, tell me about Johnny. They'll say, describe all, the medical things, and I'll ask more questions about, well, no, I want to know about them, what makes them smile, what makes them laugh. And that gets to the heart of who they are. And then families will say, and lately that's just not been the case. The light in their eye is gone. I look back at their medical record and they've been in the hospital for 5 years. So if I'm rather ignorant to what's actually happening at home, I might say, hey, they haven't been in the hospital, but life must be great. But you actually ask the family and they say, no, things are just different. They don't smile when I come in the room. I can tell they're tired. I'm not sure that I want to keep doing this to them. I'm not sure that they want to keep doing this type of thing. So I think those are really important questions to ask about what does that decline look like, whether it's in the hospital and obvious to us, or whether it's at home and maybe more obvious to the family if we ask the right questions. And then the third part of this, so you have a bad diagnosis that we can't cure. You have some sort of a clinical decline, like that graph that I just showed would suggest. And then the third part is really the response. How does the family want to respond? Because for me, and thankfully, I think for many of my pediatric colleagues, that's a really important part of being hospice minded, or some sort of there has to be some hospice spirit in there somewhere, because the goal of hospice overall is to keep people at home, including children. So if a family tells me, well, no, of course, the next time they get a pneumonia, the next time they have respiratory distress, I'm running right back to the hospital. I'm calling 911. There's no thought in my mind about staying home. I'm really hesitant to put those kids on hospice, even if their decline is pretty obvious and they clearly have a diagnosis that we can't fix. Because to me, there's no pathway to potentially stay home. And that's the third part that I really need as a hospice provider to make it to really legitimize being on hospice. Could you imagine a scenario where you would call hospice rather than call 911, rather than throw your child in the back of the car and run to the hospital? Is there a pathway where hospice would be helpful to stay at home potentially? Now, of course, we never know what a family will actually do. But as we're assessing this with a family, those are the questions that I think are really important to ask. Is there a way? Or is there a pathway in your mind where you might do something different, where you could lean on hospice rather than the traditional way of back in the hospital when crisis happens? So those are the three. criteria. And again, this isn't just me, and I haven't really seen this published anywhere, but I do know in talking to plenty of peds colleagues, I must have learned it during my fellowship that this is sort of the three-pronged approach we take. And typically it's needing two of the three of those. Now, I think the response is a really important part. The patient population where the response is less important to me, quite honestly, there are some diagnoses where I'm obviously always concerned about how a family will respond. But even if they tell me we're going back to the hospital, we want to be in the ICU, we're going to intubate, certain diagnoses, I'm like, that clearly we're not in the hospice realm. But certain things like cancer, I would still put a patient on hospice. And we'll talk more about concurrent care and how that works. But in those patients that have a disease process that clearly is going to progress no matter what one does, right? Like a metastatic relapsed cancer, that's where I still would involve hospice, as we'll get to. The spoiler alert, we can do that in peds, which many of you already know, but that changes how I approach these three different categories. So going back to our 6-year-old patient, is that someone who we feel would be hospice eligible? Now, obviously, I'm already painting the picture of, well, I think so, but the problem is, it depends when you're talking. Nowadays, I would say yes, as we'll get to, but the problem was before 2010, that patient would look much different when it comes to a hospice lens, because as many of you know, the patient I described comes with a whole lot of medical intervention. The fact that he has a tracheostomy probably gets him 8 hours of private duty nursing 5 days a week in the state of Michigan, depending on his insurance. If the child's on a ventilator, that often comes with 12 hours or more of private duty nursing, depending on insurance. Now, could have a whole nother conversation for a long discussion about private duty nursing. Who's eligible? Does it actually exist depending on where you live? Can you actually find the hours? Can you stay in the hospital until you get the hours filled? Can you leave the hospital with none of it? Fascinating conversations. But suffice to say, a child like this is typically eligible for private duty nursing. That for many of the chronic kids that we follow, they've had private duty nursing for years. And it's a very important support for a family so that they can rest, they can shop, they can work, whatever it might be. The child I described also has a pretty significant seizure disorder on 4 different antiepileptics, many of which are very expensive and cost thousands of dollars a month. They also are still followed by specialists. They see neurology, who's managing those seizures. They see pulmonary, who's managing the ventilator. They see cardiology, GI. And then if they're an oncology patient, they might still be getting palliative radiation or disease-directed radiation. I'll talk about why the language matters in a few minutes. And families may want that because that's keeping the disease at bay. It may not be curative, but is keeping it at bay. And all of these things listed here made families have to choose back in the day about either foregoing these things in their traditional hospice sense. Okay, I don't want chemotherapy anymore. Now I'm going to shift to hospice. Or not having the hospice support and continuing these things, which may, as I pointed out, not necessarily cure the disease, but might prolong their life, but indeed are not curative. So before 2010, families had to choose. Now, I came to this work really after 2010, so my entire career really has been after this concurrent care bill was passed. Now, I'm sure you've all read the Affordable Care Act cover to cover. If you recall, Section 2302 is actually titled Concurrent Care for Children. And I won't belabor the upper point. You can read all the details on there if you'd like. But basically, the summary is the Affordable Care Act has this section called Concurrent Care for Children that allows patients under age 21 who are hospice eligible, keep those words in mind, with a terminal prognosis of 6 months or less, which basically means you're hospice eligible, to receive both disease-directed and hospice services for their terminal condition. That language is really important, so I'm going to repeat it because we're going to talk in a minute about why this gets really confusing. But patients under age 21 who are hospice eligible, they have a prognosis, as best we can gather, of 6 months or less, can receive disease-directed therapy as well as hospice services. And I'll come back to why I'm saying it so oddly and focusing on that language in a minute. But this really was a game changer for families because what it allowed is all those things in the previous slide that families before had to say, well, okay, I'm going to give up my home nurse that I've known for 10 years, who's been in our house 8 hours a day, 5 days a week. I'm going to give her up so now we can have a hospice nurse come in once a week. Obviously, hospice nurses will come in more often, but it's not private duty nursing. It's not that shift nursing that supports families at a different level. And no family in the right mind was going to do that until these stipulations allowed both to exist at the same time. So again, an update in this lecture for this year, I found an interesting article from just this past summer that was pulled together by, I think, a National Hospice Alliance of some sort, looking at pediatric hospice and the state of concurrent care. Maybe not surprisingly, this was put together kind of in anticipation of changes to the Affordable Care Act and the concern that with whatever cutbacks, rollbacks might happen, that concurrent care for pediatrics might also be at risk. So they're trying to get a sense of who's using it and whatnot. So I wanted to share that data a little bit since it is kind of newer. Spoiler alert, it's also very messy. It's pediatric data, which at its heart sometimes is smaller numbers and messy data. Almost 300 hospices responded. I was actually quite surprised to see that 74% admitted pediatric patients. So that's over 200 hospices across the country. Maybe it shouldn't be surprising. If you look at our state itself, I realize there's lots of hospices who will probably say yes to a pediatric patient, maybe. Ones that have pediatric services, there's probably 3 or 4, depending on how you look at it. And again, there's been some mergers as of late, but 3 or 4 in our state alone that will say yes to peds patients. What this doesn't describe is what does that service look like? Does it have dedicated pediatric nurses, or are these hospices who take 1 or 2 pediatric patients a year? My guess is most of them are that, because there are very few hospices that have dedicated pediatric programs, meaning nurses that only take care of pediatric patients. What's interesting is of those hospices that responded and admit patients, only 38% utilize concurrent care services, which I think is shockingly low. If I think about my hospice census, which is around 20 patients or so right now, the vast majority are utilizing some form of concurrent care, which will be obvious in a minute when I talk about what does that actually mean. But that also is a problem with this study, is half of the responding hospices didn't actually know or didn't give an answer for how do you define concurrent care, which in itself is a bit of a problem, and really speaks to the issue of concurrent care state to state. Looks much different. So that federal guideline said that Medicaid has to provide hospice services in appropriate situations for children in addition to disease-directed therapy, but it didn't say how to do it. It left it to the discretion of each state to figure out. So this data really supports that half the time hospices don't know what concurrent care means. Only 3% who did give a definition included something about a 6-month prognosis. Only 3% actually mentioned anything about age. And just over 40% actually included a phrase about not having to choose between life-prolonging curative care and hospice, which I find interesting. That language, again, if I'm very clear about language, if we're talking about curative care, we probably shouldn't be talking about hospice, right? Those things are not the same. That's why I use the term disease-directed so much. But it's fascinating to me that even of the hospices that admit peds patients, most of them don't even know what concurrent care really means, which speaks to the confusion. Now, the same study looked at or mentioned in a sort of qualitative way what are successes, where is hospice helpful, and it's in ways that we obviously, as palliative care and hospice folks, would understand and assume that it provides greater level of support for family, better satisfaction with care, more choices, better pain and symptom management, all the stuff that we brag about doing all the time. So obviously it's helpful when you have hospice involved. We all know that. We all believe that. But the bottom part of this graph speaks to the challenges which exist across the country when it comes to concurrent care, with unclear guidance from Medicaid offices from the state to state. Most of these hospices, or many of these hospices, felt that was an issue. Concern with meeting regulations, which is what I hear all the time from adult hospices about, well, we don't want to do concurrent care because it's too confusing. We don't want to risk regulatory issues. Patients and families finding it complicated, unclear, and then not having access to staff with pediatric expertise is a big one as well. So I won't belabor that more, but I want to move on to Michigan, because I do think in Michigan we're in a different spot. And this might sound like I'm bragging a bit, but I think the teams that I have the honor to work with from a pediatric perspective really have figured this out really well. And we can cover most of the state and cover it really well for our pediatric patients. Now, as I said, every state is different as far as how do they define concurrent care. I'd argue the eligibility really should be the same across the country based on the federal guidelines. But I want to discuss this for a bit, and it goes back to how I define concurrent care because it is for patients under age 21. You cannot be 22 and try to invoke concurrent care and bill insurance the way you would if that patient is 18. These in Michigan, you have to have Medicaid or Children's Special Health Care. Children's Special Health Care is sort of the safety net for children with chronic, complex, serious medical conditions. The vast majority of kids that I see have Medicaid and or Children's Special Health Care, but it's not always true. We do have patients occasionally that only have private insurance, and private insurance does not need to follow these guidelines because they're federal guidelines that then fall to the state. Occasionally, we can convince private insurance they should do the right thing and pay for concurrent care and hospice at the same time, but it's a much bigger fight, as you might imagine. So one of the first things that we do, in all honesty, one of the first things that my hospice team asks me after I talk about hospice with a family is, what insurance do they have? And oftentimes, like, oh yeah, I probably should have checked that. But I'm so passionate about this care being offered that sometimes I forget that part and we figure it out, like any good physician or provider sometimes does. And then I have a great team that will remind me of, hey, we kind of need to pay for this too. And I say, yeah, we'll figure that part out. It's okay. These kids, again, have to have a terminal prognosis of 6 months or less as best as we can tell. Again, I could talk for a long time, as I mentioned before, about the challenges of prognosticating in this patient population in pediatrics in general.
So Brad, we've got a question here.
Yes.
I know I was just on service with you guys and should know this, but is Children's Special Health Care a federal program separate from Medicaid?
No, it's a Michigan specific program. So most states might have something similar. So what it does is it fills in the gaps that Medicaid or private insurance wouldn't pay for. So depending on one's income level, you'll qualify for it automatically. You need a diagnosis for your child, which again, most kids that we see would meet that criteria. But there are also income levels. So some families do have to pay into it to have that extra benefit. But depending on the condition, it almost always makes sense for a family because it does cover so much extra things, copays and hospice, for example, that private insurance might not.
So like kind of like a state government program?
Yes.
Then,
Yep.
sort
Yep.
of. All right.
Yep.
Okay.
Yep.
So if a family had like, I don't know, Priority Health or Blue Cross, they wouldn't necessarily need Children's Special Health Care?
Well, it depends. There are things that copays and other things that depending on their insurance and how good it is, that they would still be on the hook for. And that depends on income level. Oftentimes it's brought up, we discuss it, that is it worth it to have Children's Special Health because you might pay $5,000 into it, but your copays and everything else are going to be $10,000, and that would be covered by Children's Special Health. So it might make sense financially. So, but again, the vast majority of kids that we see, if you look at our children's hospital in general, the vast majority of kids have Medicaid or Children's Special Health already when we're seeing them. So it's rare that we, encounter those situations. But, and really, what concurrent care means is all services not covered by hospice, and I'll get to more of those details in a minute, must be managed by a pediatric subspecialist for concurrent care to apply. So as a hospice physician, I am not writing for things that oncology is writing for, right? That will confuse insurance. So it's a very clear delineation of this is an additional benefit that a patient and family get in addition to the regular care that still continues from their subspecialist. That's a really important part because when it comes to payment, what this means is hospice pays for certain things that are deemed hospice care, and concurrent care, i.e. regular insurance, continues to pay for those other therapies that are not hospice care. So I think from a general mindset, the easiest way to think about it is symptom management. If it's symptom related, hospice is going to pay for it. Pain, dyspnea, nausea, vomiting, bowel bladder management, anxiety, depression, emergency seizure management is all hospice care. And hospice will be on the hook for those medications. We'll get to supplies next. Versus if it's disease-directed therapy, very important language, right? Or I put curative still makes the list. I should just take curative off because in my mind, if we're talking curative, we're probably not talking hospice. Because if you take an oncology patient who has a 95% cure rate for their standard risk leukemia, that is not a patient that I'm going to endorse putting on hospice because they're going to be cured. If they're in that small category that aren't, yes, we'll talk about hospice versus a DIPG patient, diffuse intrinsic pontine glioma. It is not curable. There might be disease-directed therapy with radiation or some other more experimental therapies. I will put them on hospice day one because they will absolutely qualify because their prognosis, even with those things, their prognosis is still terrible. And the state is very clear about what hospice should pay for versus what insurance, Medicaid, or Children's Special Health would pay for in this scenario. And it's things like seizure management. The baseline seizure meds that are really expensive are still paid for in the traditional way and managed by their neurologist. Chemo radiation for cancers, that's not stuff I'm writing for as their hospice doc. Infusions for autoimmune or metabolic patients are all still written for and managed in the same way. Hospice is just this additional service that comes in to support the family and take on the symptom management part. Same thing applies for medical equipment. Medical supplies related to comfort, oxygen itself, a suction machine, a hospital bed. Those are all things that would fall under hospice being responsible for. They provide the hospice nurse, obviously, social work, spiritual care, the hospice physician, those kind of things. Life prolonging measures, ventilators, high flow nasal cannula, BiPAP, CPAP. Those are all paid for in the traditional way under concurrent care guidelines. Same with transfusions, blood, platelets, albumin, IV fluids are not a hospice plan of care. Now, I don't know if that's done sometimes in the adult world or not in different situations. Typically, that's not something we do in hospice. So I have to remind my oncology colleagues sometimes that, yes, your patient's on hospice. No, that doesn't mean we're going to do IV fluids at home on a daily basis. If you feel they need that, you can write for that in the regular way. And if you can get it done at home, that's great. But that's not under the hospice realm of responsibility to do. So we need to keep it pretty separate. Same with transfusions, Mironone drips, and those sort of things. Now, the state has actually helped us out. I remember when I first came to town 13 years ago, I was part of conversations in Lansing about these diagrams. I had no idea what I was talking about or what I was doing because I was young and new and confused. But basically, a group of pediatric experts were sitting in a room trying to figure out in a nice, clear chart, what does hospice pay for and what does concurrent care pay for? And this is actually from the state of Michigan. Again, similar to the Affordable Care Act, I'm sure you're all very familiar with the Medicaid Provider Manual. Section 6.8 is literally called Concurrent Hospice and Curative Care for Children. I hate the fact that it says curative on there. It gives a different message, but that's what we're stuck with for now. Probably should be updated because it's been a while. But you can see there's a list there of what falls under hospice, what falls under concurrent services, and it's pretty clear. Narcotics, antiemetics, hospice covers. IV fluids, TPN, concurrent care covers. Hospice is not paying for those things. Similar with chemotherapy, with ventilator, things like that. Now, the confusing part is that column that says both hospice and concurrent care services. So tube feedings, who covers that? Well, if it's a continuation of previous ones, hospice will pay for it. If you're starting a new one, then concurrent care is supposed to pay for it. So there are nuances that get super confusing. And I'll mention my go-to again a little bit later on. Her name is Chantel Curell. She's the statewide nurse manager for pediatrics for Hospice of Michigan. And she is an expert in this concurrent care and how to make sure the right people are paying for the right stuff. So she's my go-to because the system, while we try to make it simple with these charts, it does get a little bit confusing depending on what interventions you're talking about. NHPCO tried to help in a more formalized way. This is on their website about concurrent care and a nice, simple to follow algorithm about medications and things if a child enrolls in hospice. I joke because I don't think this is rather busy. Basically, what it says, I'll save you from having to read all of it, but it'll be a resource that you'll have for future. Is if it is a symptom, if it is a hospice symptom, then we're going to cover those measures. We're going to cover those interventions, cover those supplies. If it is a disease-directed therapy like chemotherapy, like seizure medications, then like TPN, those should be covered under concurrent care instead. So there are resources out there to try to help. Sometimes it seems to make it more confusing with this type of algorithm. And as I mentioned, please keep in mind that these guidelines differ state by state. So this is actually an interactive map. I was just using it yesterday looking at every state guideline. They all look a little bit different, and how people approach concurrent care differs vastly state to state and probably hospice provider to hospice provider, depending on one's view of concurrent care and that idea of prognosis. I have a colleague in California who works with two different hospices. One has, I believe, 90 concurrent care patients, and one has 50 concurrent care patients, and he will label them differently. He'll call this a hospice patient and this a concurrent care patient, which I understand sort of, but I don't tend to approach it that way because at the heart of this, from my perspective, this patient that I'm enrolling on hospice has to be eligible for hospice. They have to have that prognosis as best as I, with a clear conscience, can say they are at their prognosis is 6 months or less if their disease takes its natural course. So it does get a little bit challenging because it is so subjective, and states have different ways of looking at it and different resources to pay for some of these things, depending on where you are. I mentioned that when a patient is enrolled under concurrent care guidelines, their seizure meds, their chemotherapy, their radiation has to be managed by a pediatric specialist or by a pediatrician. So sometimes we'll have their PCP actually order some of the medications that aren't truly part of their hospice plan of care. This is the form that every provider gets. So our hospice sends out a whole packet to providers. I often have to educate my pediatric colleagues of, yes, they're on hospice, but I still need you to do your job maybe a little differently. Don't make them come in every 3 months. That seems silly, right? You can do this via telemedicine if you need to. But this form, as you can see, basically says who the provider is and what they're providing. I am responsible for these seizure medications. I'm responsible for this chemotherapy. This document then helps on the insurance side to be able to tell Medicare, Children's Special Health, look, these physicians, these providers are involved still. The billing should go to them for these things versus hospice for these other parts. So this has been a fantastically helpful document that our program has shared with other hospices as a way to help them say yes to PEDS patients of this is what you need to get from the specialist to be able to pull this off in appropriate ways. So I obviously am a big fan of concurrent care, as you can probably tell. As I mentioned, in the past, before this was possible, we had children who would not choose hospice because they would lose private duty nursing. They would have to come off their ventilator right away. Now, again, these are all conversations we have with families, obviously, from the broader perspective about, is that ventilator still helpful? Are those tube feeds still helpful? Those are different conversations for another time. But concurrent care allows us to do this. So if I have a patient who's stuck in the hospital, and I've had this happen many times, and teams don't know how to get them home because they're on high event settings, too high event settings, I say we can do this. If the family's in the right state of mind regarding will they escalate further, and if the answer is no, this is where when bad things happen, we aren't going to be escalating settings. We don't want to be back in the hospital. That's very hospice minded. I'll entertain the idea of enrolling. We couldn't do that without concurrent care. It allows us to continue chemotherapy and disease-directed treatment, whether it's cancer or otherwise. But again, saying palliative or curative gets really confusing because palliative sounds a lot like hospice. So if I have an oncologist saying this is palliative radiation, insurance could look at that and say, oh, it's palliative radiation, the hospice team should be dealing with that. So I have to be very specific with my referring colleagues to ask them to not include language of curative of, oh, we're hopeful this treatment will be curative. Well, we probably shouldn't be on hospice if that's what we really think is going to happen with this treatment. Another big benefit is you don't have to come off a hospice to be back in the hospital. As I mentioned, the third criteria I have to enroll in hospice is a hospice mindedness. It doesn't mean a family won't come back to the hospital. The classic situation we have is a child leaving the NICU in the first few weeks of life with a super rare genetic disorder that isn't cured, isn't curable, will be progressive. And a family says, we don't want to be aggressive. We don't want to go down a trach vent path. We know what this means in the big picture. And they go home with hospice. It's very appropriate. And the child actually does better than we thought. And they get to 3, 4, 6 months old, and they haven't had a big event at home. And now they're in a little different scenario. And I could tell you many stories right now that families are now like, maybe we would want to go down an aggressive path because we've learned a lot from our child in these 6 months. And they end up back in the hospital for a new symptom, a new complication that has arisen. Is that part of this process? Is it just a pneumonia that maybe they need a little bit of support for? Those things are okay under concurrent care. certainly for the general floor for a new workup of symptoms and things. The ICU, I used to say no in this, and now I've changed it to maybe, because it depends what they're there for. If they're in the ICU to be intubated and to absolutely go down a trach vent path if they need to, I would question how hospice minded we are and have a conversation with the family about it seems like we're in a different spot. Why don't we should probably come off a hospice because we're now down an aggressive path. We can revisit it later. But that's why I say maybe. So where I take issue though is if a family does choose to be in the hospital week after week, month after month, I would probably choose or have a conversation about coming off hospice because at its heart, I think hospice should help a family and child stay home. And if month after month they're in the hospital for a week at a time, I'm not so sure hospice is the right thing. I think we're not quite in that hospice spirit, and I'm not sure that aligns with the family's goals if they want to be back in the hospital that often when complications arise. And that's one of the challenges of concurrent care. So I love it, and I also at times really struggle with it. Part of it is, as I mentioned, and I won't perseverate more about who pays for what. It gets a little bit confusing. The answer is not hospice pays for everything, which is usually the adult model. And I have seen that gone awry in different hospices who do take on peds patients. They don't want to deal with concurrent care, so like we'll just pay for it all. As you can imagine, that puts hospice in a tough spot because now you're paying for things you probably shouldn't. And while we don't love to talk about the finances, we also have to, that we can't bankrupt our hospice services just to say yes to a peds patient. PTOT is a challenge, and I put this on there. Admittedly, that this challenge seems particularly for Corewell and Priority Health. We're running into the most problems. You can have physical therapy and occupational therapy as part of your care plan while on hospice under concurrent care guidelines. But we've had some people who provide this at home, Corewell in particular, say we can't do that if you're on hospice because they're both home services. And that's simply not true. I've had plenty of patients outside of our immediate area receive home physical therapy and home hospice without an issue under these guidelines. So I have to fight those battles with providers or agencies who don't understand how this works. Sometimes hospice is used as a ticket out of the hospital. I think that's the next point I have there. Yeah. Because it's presented as, hey, there's this great benefit with concurrent care. Nothing needs to change. You can continue everything just as is, and you just add hospice to the mix. Which the spirit of that might be true, but also something has to change. And that something is a family has to be at a spot where they understand their child is at serious risk of death in the next 6 months. And there's some pathway, as I keep mentioning, where they would want to stay home and rely on hospice. So I've been in the situation where we tried hospice on, and the first crisis that arose, the family called 911. They may have let hospice know, hey, by the way, I'm calling the ambulance. And hospitals will say, do you want a nurse to come out? And they say, no, absolutely not. We're going right to the hospital. That's not very hospice minded in my mind. And it happens once we deal with it and we talk to a family, but then we have to be really honest of, is hospice actually beneficial if you don't see a path where you would lean on them to potentially keep your child home when that crisis arises? So I'm not a fan, and we've been, that's happened before where a hospital will say, well, we don't know what else to do. This is really bad. You should have hospice. And a family in no way is hospice minded. So we have to be really careful with those conversations. And then another challenge is what happens when a patient turns 21. So, for example, oncology patients can continue their disease-directed palliative or disease-directed chemotherapy. But once they turn 21, that they can't be on hospice anymore and continue to receive that monthly oral chemotherapy because then now hospice would be on the hook to pay for it. Now, you can all tell me whether or not you would do that for a period of time or not, different conversation. But this is an important part that sometimes we have to enroll. I have a patient right now who receives monthly or actually every 2-week infusions for a rare metabolic disorder that's not really curative and will develop antibodies to them probably pretty soon, but he's turning 21 in a couple of months. So we can't really have hospice on board anymore. We're going to shift to really an adult home palliative program for now. When things really turn a corner, then you can get back on hospice when those infusions aren't happening anymore. So as I mentioned, I have a wonderful team that I work with I still say Hospice of Michigan. So North Star is the bigger agency that really covers almost the entire state of Michigan through Hospice of Michigan, really on the west side of the state. Arbor Hospice in Detroit and Ann Arbor, and then Centrica is the newest sort of area that Hospice of Michigan or North Star has merged with. So I now help take care of patients in the Kalamazoo area through a dedicated pediatric team. We have a dedicated peds nurse and social worker, which has really been a big step forward. Not that they weren't doing great care in that area, but it allows us to focus on peds in a different way. I mentioned Chantel, who was a field nurse when I first started, so I sort of grew up in hospice with her. She is now the statewide operations manager for pediatrics, and she is my go-to when it comes to pediatric questions and concurrent care. And she is a resource for anybody. She is very passionate about this care for pediatric patients. So if any of you are caring for children that are outside of our service area, we all want to be a resource to help adult hospices say yes. And she is willing to talk to anybody and walk through concurrent care and how to bill and how to make this workable for adult hospices. So I realize I'm running at the end of my time. I always share a picture of my kids. I realize I've stopped sharing more serious ones. This is them. They're goofy. My son is super happy at his graduation about his siblings messing with him. But these are the ones that keep me doing what I'm doing. So thank you all for listening. I guess I did talk longer than I thought I would, but happy to answer any questions before we move on to the case.
Well, yeah, I've got a question. The three of us in this room have had some interaction with IU and Riley. I think we all share a wonderment as to how Indiana is not involved in pediatric hospice. And I guess and off the top of my head, especially after listening to this lecture, the question is why, and is it insurance or hospice connections or institutional inertia? What are your thoughts on that? And
yeah, that's a great question. And I think from what I've heard from folks on there's a lot of hospices like in Indianapolis, but they might take on a peds patient now and then. I think in general, and that's why I feel like we're fortunate in Michigan, it takes a hospice being willing to put resources towards pediatrics. Now, that one study I showed that had some 200 hospices that admit peds patients, I would argue the vast majority of those, my guess is it's not peds specific, which might be okay, right? It's an adult hospice nurse taking on a peds patient. It might work out okay. I think where we're fortunate in Michigan, what Hospice in Michigan and North Star have done is really put resources towards dedicated peds teams. That census looks way different. And obviously financially, the cost is going to be different when you have a hospice nurse that has 8 pediatric patients, and that is her entire census, right? You all work in the adult world would know how well adult hospice would work if that was what the census looked like. But in the peds world, things are so nuanced and I think time heavy that's what it takes to really do this well, is have dedicated pediatric teams. And quite honestly, I think for many adult hospices, that's just not financially doable. So there's obviously a very large philanthropic component. And specifically, I can't speak to what Indianapolis or Indiana looks like, but I think it would take a hospice being willing to put resources dedicated towards peds to build up that pediatric expertise. So it doesn't feel like it's a one-off of, okay, we'll take this teenager. This is going to be tough. Yeah.
So it sounds like from what you're describing, this ball gets pushed from hospices outside of the institution. And I kind of look at IU Health as the name of the game in Indiana. So it's just from my point of view, it seems like the onus of responsibility ought to be on IU Health and specifically Riley to start this initiative. And the reason I'm pushing this is, well, I know some people in Indiana and I know some, at least anesthesia leadership types of people with very public health minded perspective. One of whom used to be the Surgeon General. So I'm going to give him a call. But I kind of want it. Well, I will. And I kind of want it, as you might imagine, I'm not politically correct and I'm not particularly institutionally minded, but I want to know how to ask the questions and how to kick them in the ass.
Well, I think one question is, does IU, do they have any hospices, right? So I think that's part of the issue as well. A lot of academic places don't have their own hospices. So I realize my life is very confusing. I work for Corewell that has adult hospice services on the west side of the state, that's not who my pediatric programs are through, because Peds has existed here before Corewell had in a hospice. So Hospice Michigan had Ped programs for 30 years. So I think one issue that you might run into, I agree, it would be great if the hospitals themselves push this, but I don't know if IU's health system has hospices. Many don't.
Right.
Many academic places don't have hospices, so the hospice programs are run outside of those institutions. And are those institutions willing to take on a higher cost program potentially like pediatrics?
Hey, Brad, I'm gonna let Bruce know. So Matt Meisner might be a guy that might carry the pitchfork with you.
I was just gonna mention that too. Center for Hospice Care in South Bend, Matt Meisner, came through the program last year. He's Peds palliative and they've got a Peds program going in South Bend.
Huh.
So that may be South Bend. Don't confuse.
It is South. It is South.
It is South Bend. Yeah.
Shawaka, actually.
Yeah.
But,
That's like almost Michigan.
it is, but I mean,
They're expanding into Michigan too. So if anybody has Peds on the border, they're moving into Michigan. They can see 4 right now, but by next month, they're gonna be unlimited in the state. So
he's
southern border.
he's the kind of guy that has the fervor that you do to get seriously. He
Okay.
you should.
No,
Yeah.
that's helpful to have those connections and know how to help connect dots. So-
Yeah, and he gets patients referred from Indiana. They're down seen at Riley and they are from South Bend. And so he would be a good resource that would
Yeah.
He
know
even
what
did
exists.
rotations in Indianapolis last year.
Yeah, I expect there's a Riley connection because Riley covers the state. So that's helpful.
I had a question for Dr. Hemker, if that's okay. My name is Esther. I'm looking at the program, but not currently a part of Trinity's fellowship. But I actually wondered about prenatal hospice, if that's something that you get involved with at all.
Yeah. Yes, absolutely. And thank you. I pointed out I should include that to make sure to mention it. So from the palliative side, we certainly get a lot of referrals at our children's hospital prenatally. We work really well with MFM and the NICU to meet those families before their child is born to talk about what that future might look like. And again, the same uncertainty around, the child won't survive to birth and they might survive. We live in that uncertainty. And then from the hospice side, there is a perinatal hospice program. So if it's a condition that we assume the child will die shortly after birth, and we're thinking this probably will be a hospice situation if the child does survive the birth period, we will refer to the perinatal programs of Hospice in Michigan. That is really a social work connection in the beginning, but it is nice to have a warm handoff then of you've met our palliative team, we've had big conversations. If we're in a situation where you want to get home with your child in those first couple of days, already being involved with the perinatal hospice program is a great connection to help that happen pretty quickly. So that's a big part of what our teams do.
Okay. Do you know how widely known it is amongst OBGYNs and midwives in the area? Like that this is an option, because I don't sense that it is widely known.
That is a fantastic question. So I think it's more widely known at Corewell, where our children's hospital is part of Corewell. But we have, and just in the past few months, we've had exactly that question come up. Interestingly enough, from fellows or former fellows of the different fellowship programs have reached out and said, I have this friend who's dealing with this situation prenatally. And what you just said is true. Their OB didn't even endorse the idea of talking to palliative care or hospice and just wants to poo-poo it and ignore it. And it's not fair. And our whole team is super passionate about, yes, how do we make sure that we reach those families who are cared for by other health systems? So it's on our list to try to figure out how do we reach out to MFM or OB at Trinity in Grand Rapids or Muskegon or U of M Health West to make sure they know, like, hey, we're here to support these families even before the child's born as they navigate these decisions. So I agree with you. It's not as well known as it probably should be, and we're trying to work on that.
Okay. Thank you. Appreciate you.
But in the meantime, what I always tell people is just reach out. And that's why I reach out to our team and say, hey, I know of this situation. Do you think it would be helpful? And then we have ways that we can connect with those providers and make sure that they, get a referral basically, and then we can take it from there.
Okay, great. Thank you so much.
And Esther, that's not a local problem. That's a national, universal problem that people
Yeah.
have with palliative care and pediatrics and the perinatal space that people don't
Mm-hmm.
think of it or don't know or don't have the resources in some places. So
Mm-hmm. Mm-hmm. Yeah. Thank you.
it's a struggle, bro.
Yeah.
Well, thank you, everybody. Sorry, Joel. See, it went longer than I thought it would. So
I mean, I had no worries. So,
in my defense, it was the questions that went longer, not my talking. So
well, there you go. So thank you again, Brad.
thank you all.